Great. So it's 2 minutes past 12. I'd like to kick off and just say thank you and good afternoon to everyone for joining us on today's session about paediatric blood cultures. I'm Professor Elaine Cloutman-Green, and I have a vested interest in this as I'm an infection control doctor at a children's hospital. So obviously, paediatric blood cultures is something that is really high on my list of considerations, and is something that's so important to us clinically in terms of managing. But I also have a vested interest because I have been involved in the blood culture task and finish group for over 3 years now. We started the work before the pandemic, and so it has been a bit of a labour of love getting this information out and the guidance out to you. Please forgive me, I am rather croaky and snuffly still. I had my first case of SARS-CoV-2 last week to celebrate the 3rd anniversary of lockdown. I finally caught it, so I am a bit full of snuffles. We have Dr. Jim Gray on with us as well. He's going to do a great introduction for himself. But the way today is going to work is that we have 2 short presentations for you. One on the really practical aspects of and a bit of the background about why paediatric blood cultures are so important, and then one a little bit on the implementation of the new guidance and things to think about in terms of how you might set it up and get it going. You'll see that there's a Q&A function. So after we've done the 2 short presentations, the hope is that we will do some co-creation and we'll do some knowledge sharing. And so please do feel free to put any thoughts, comments, questions and answers into that Q&A function. And then once the presentations are done, Jim and I will try to go through and try to help signpost and curate some of those queries. So I'm now going to hand over to Dr. Jim Gray, and I'm so grateful he's here to join us because he has so much knowledge on this subject. Over to you, Jim.
Great, thanks very much. For those of you who don't know me, my name is Jim Gray, and I've been a consultant microbiologist here at Birmingham Children's Hospital since 1995. And in fact, I've been here for so long that when I started here, we didn't actually even have a continuous monitoring blood culture system. And I think back to one of the first things I did was put in a business case to get a system, and the radical difference it made to pediatric blood cultures, in that suddenly we were isolating things from blood cultures that we hadn't been seeing for the year or two before that. I think that's kind of like where I'm coming from with this, because I've lived through an era where I've seen one change in blood cultures, which was getting the technology right, and seen the dramatic impact that can make on positivity rates and so on. And so I think the next step now is to try to get the actual blood culture collection right, because there must also be some potential to make things better than they are at the moment by doing that. And that's very much the theme of what my talk is going to be. So I've kind of not used this version of Teams before, and I feel slightly nervous because I can't actually see what you could see, but I'm trusting that you can see my slides, and that somebody will tell me if they can't. So what I'm going to do, at least what I'd like to do, if I could move my slides along, is I'm just going to say a few words about why I think the accuracy in pediatric blood cultures may be even more important than it is in sort of adult practice. What we can do about getting the blood volume right, although it's kind of slightly out of the sort of main theme of the talks today, talk a little bit about when we should be taking blood cultures from children, and then really sort of give my views on different standards for different ages. But I think one of the other things is that this is not an area where there is a tremendous amount of research. And I think that we're probably going to open up more questions than we can provide answers with today. So hopefully that will kind of lead to some interesting discussion when we get to the end of the presentations. So I think really, from my point of view, for too long, we've kind of accepted that blood cultures in children are not easy to collect, and therefore it's okay to not be very good at doing it. And there's lots of reasons for that. It's difficult sometimes to collect blood cultures, not just getting the right volume, but actually physically restraining a child who doesn't want to have a needle put in them, to actually get blood from them. I think there's also a culture that permeates through pediatrics, that because it's acceptable to take smaller volumes of blood from very small children, it's kind of, you don't need to think about trying to get the maximum amount of volume you possibly can from older children. And goodness be, some of the children that we see coming through the hospital are definitely young adults. They are not children. And then the other thing is that I think there's also a sort of sense that everybody wants to look after children. So the person doing the venipuncture themselves probably wants to make it as painless and as short-lived as possible. They don't want to do multiple venipunctures. And not only does the person doing the venipuncture not want to do that, but you've probably got a nurse standing over you saying, no, no, you can't do that. We've got to think about the child's interests. And of course, you're likely to, in many cases, to have parents or carers around as well, who are not going to want to see their child crying. So I think the end result of that is that many people who are doing a venipuncture get whatever blood they can, sigh of relief comes out, and they just put whatever they can into whatever bottles that they need, including a blood culture bottle, and we don't end up getting very good samples. But that's not what we want, because I think one of the differences between adult practice and pediatric practice is that there are lots of national guidelines that actually tell us to use a negative blood culture to stop antibiotics. Mention first of all the nice guideline for neonatal sepsis, which in its latest iteration covers both early onset and late onset neonatal sepsis. So it would include even babies coming back to hospital after they've been discharged after birth. And for early onset sepsis, there's very clear direction that you should consider stopping antibiotics after 36 hours if the blood culture is negative. And for late onset sepsis, a little bit longer, 48 hours. And of course, there are some other criteria to consider before stopping blood cultures. But I can think of an example in our hospital not too long ago when we had a baby who at about 4 days of age, had an E. coli in blood cultures. And when we kind of did the case review into that, that baby had a negative blood culture at birth and a CRP that never went above 11. I think it just crept above 10. And the decision was made to stop antibiotics on the basis of the negative blood culture and the low but not normal CRP. And then a day or two later, the baby became clinically unwell with a proven E. coli infection. And I just left thinking, well, if they had, was that an example of a blood culture that didn't have enough volume in it, first of all, and might it have been positive if there had been more volume in the initial blood culture? And whilst we've got the nice guidelines saying that for neonates, I think it's pretty widely used in general pediatrics, certainly judging by the number of phone calls that we get in the lab after ward rounds saying, are the blood cultures negative because we want to stop antibiotics and send this patient home. So I think there is a lot of emphasis on negative blood cultures in making clinical decisions in pediatrics. The other thing is that I think we're living in an era of increasing antibiotic resistance. We are encountering literally hundreds of children a year who are colonized with ESBL producing bacteria. And I think, we're possibly not seeing that translating into too many bacteremias at the moment. But looking at our rates of resistance to commonly used antibiotics by quarter for the last 2 years, you can see that we are running pretty much all of the time at something like 50% or more of our Enterobacteriales from blood cultures at the Children's Hospital being Comox-Clav resistant, with a fair number being ceftazine resistant as well. And so I think is another reason why we need to get our blood cultures right, because we need to know that we're giving patients the right antibiotic as well. And the challenge then, I think, really comes down to trying to educate people as to just how much blood we need to get a reliable blood culture bottle, because there have been countless studies done over the years where people have taken blood samples and put them directly into pour plates or otherwise done quantitative counts on them. And outside the neonatal period, at least, most people with bacteremia don't have more than 10, and quite often substantially fewer than 10 culturable bacteria per mil of blood. So, you can imagine if somebody's only got 2 or 3 bacteria per mil of blood and we're only getting a mil, then those bacteria will all have to grow. And the more bacteria you have in the blood culture bottle, the faster the blood culture is likely to signal positive, which if you're relying on a negative blood culture at 36, 48 hours, then becomes important as well. So I think it really is important that our clinicians understand how few bacteria or how few culturable bacteria there are in a mil of blood, and anything less than a mil of blood carries a risk that actually there'll be no bacteria at all, even in a patient who's got true bacteremia. Okay, so I think the first point I would make is that an adequate blood volume is imperative. Anything less than 1 mil from a child of any age is likely to be suboptimal. And as I've said, not only does this affect the sensitivity of the blood culture, but it's also likely to make the time to positivity later as well, which can be clinically significant. The next thing I really want to talk about is another NICE guideline, which is the NICE guideline for children with fever who are aged under 5. And I've kind of reproduced exactly what the recommendation of the NICE guideline is and the order of blood tests that they recommend, because they say there that it's the full blood count that comes top of their list, followed by blood culture, followed by CRP. And I guess the rationale for that is that actually one of the criteria for making a decision on giving antibiotics is actually the white cell count. And so they're prioritizing, or they seem to be prioritizing the full blood count over the blood culture. And of course, we've got sepsis 6 and pediatric sepsis 6 in the way. And not only do we know about the kind of, you've got to give antibiotics within 1 hour, but sepsis 6 lists even more blood tests that should be done early on. And so if you're a pediatrician and you've got all of these bits of information coming towards you, where you've got a sort of NICE guidelines saying you've got to get a full blood count early, and you've got to do your blood culture, etc. And you've got sepsis 6 saying, well, you need to have some blood, albeit probably from a blood gas to do a lactate, but you've also got to be doing U's and E's and so on. Then the temptation, I think, very much is to say, great, I've got some blood. It was a difficult venipuncture. I'm going to use this blood for as many things as possible. And the amount of blood for the blood culture bottle is going to be sacrificed. And I think that is the reality of most pediatric emergency departments. So I think that the first thing that you have to do, and I say you, but I think I have to as well, because I don't think we've got it right in our hospital, is that we need to work with our clinical colleagues to devise pathways that help everybody to navigate the way through the sort of requirement for whatever blood tests are required, whatever other investigations are required, with the aim of getting all of that done and blood cultures given when they're indicated within 1 hour. And I don't think that is as simple as doing everything at a single venipuncture. And certainly some of the discussion that we've been having with colleagues in our emergency department is to say, well, actually, there's a lot that we can do with a heel prick test. So let's do a venipuncture for the blood culture. And then once we've got that out of the way, let's go back and get some blood separately from a heel prick to do at least the biochemistry, if not the hematology as well. So I think that's one of the first challenges that I would set anybody in trying to improve blood cultures. I said I would mention something about when to take blood cultures, and I think one of the problems that we have certainly is that patients come into emergency department. Again, there's this sense that, well, we're going to be taking blood from them, so let's do everything at once. So let's do the blood culture. And many of those blood cultures are completely inappropriate. They're not necessary. Some of the better pediatricians, rather than sending every blood culture to the lab, hold on to the blood culture bottle in the department and then only send it to us after they've finished their assessment of the patient and decide that actually a blood culture is justified. But I think all of this really kind of facilitates bad blood culture practice, because it kind of, I think, devalues the importance of a well-taken blood culture, because it just becomes, I've got to do it, so I'll do it, and I'll squeeze it in with all the other things I do, rather than people really being focused on getting a nice, clean, appropriate volume blood culture. So I think my other recommendation would be, when working with clinical colleagues, is try to define clear indications as to when blood cultures should be taken, rather than taking more blood cultures than are necessary. And then the final things I really want to talk about is around sort of what volume for different ages. Because, as I said earlier, I think there is this sort of sense in pediatric practice that, children are just children, and nobody really thinks, well, actually, this is a child of a certain size, and therefore I should be aiming to take a certain volume of blood from a child of that size. And I think that there is a tendency to sort of accept that a mil of blood is fine from a child of any age. And there's also the issue of when we should consider a transition from pediatric to adult blood culture bottles, because of course the pediatric blood culture bottles generally formulated to take a smaller volume of blood than adult blood culture bottles. And I think all of these things need to be considered as well. So again, I think it's something that we as laboratory practitioners can't do on our own. And I think we do have to work with our clinical colleagues, being able to explain to them, the importance of blood culture volume and the evidence that's out there, which is largely in adults, that the greater the volume of blood that you culture, the greater the positivity rate, and try to work with them to determine target blood volumes that you should be aiming to collect from children of different age groups. I'm sitting on the fence at the moment around whether we should be switching from pediatric to adult blood culture bottles at any stage. Working in a purely children's hospital, my fear is that we could then end up with people inoculating adult blood culture bottles with blood from very small children, and perhaps even worse than that, using half the blood to put into an anaerobic bottle when there is almost no chance of them having a anaerobic bacteremia. And so at the moment, we have not switched to using adult blood cultures in any children at all, but it's still on the agenda for us to look at. So that kind of takes me through what I wanted to talk about, really, about the challenges of collecting blood cultures. The next challenge, I think, is to, after setting those standards, is to establish some sort of audit program to monitor compliance. And, I think there's been an awful lot of focus in adult practice about just recording the volume of blood inoculated into blood culture bottles. That in itself is a massive challenge in pediatrics because of the difficulty of establishing how much volume has gone into blood culture bottle when the volumes of blood are very small. But I actually think that the audit program has to be much wider than that, and has to look at other aspects of the quality of blood culture as well as just the volume. So just to finish up, really, I think what I probably kind of tried to get across to you is that nailing pediatric blood cultures is not as simple as it sounds. I think it's a real challenge to fitting in collection of blood cultures around other priorities in the care pathway for children, and particularly when just everything is slower, like gaining intravenous access and so on, but with still the same challenge of trying to complete the sepsis pathway stages within 1 hour. Getting the quality of the blood culture right, and somehow trying to get everybody involved, all stakeholders, to recognise that paediatrics covers everything from the sort of 500-gram preterm baby up to adult-sized adolescents, and we shouldn't be accepting that there is the same standard for all of those groups. So really, that was what I wanted to get across this afternoon. So thanks very much for listening. And I will see you again when we come back to questions and answers.
Thank you so much, Jim. That was really great. Can I remind people that if they have any questions that they come to mind whilst people are talking, you can stick them in the Q&A, and then we will start curating them and going through. Now we will check my technological capacity, which is often not great, and I will attempt to share my slides, so bear with me. I will try and get them up as quickly as I can. There we go. Hopefully everyone can see those. Give me a shout if you can't. It's a bit weird because on Teams you always end up presenting and only being able to see your slides, so it's a bit strange. So Jim did a great job of really talking about some of the challenges we have about collecting paediatric blood cultures, and now I'm going to follow on from his talk about the need to actually monitor what we do in order to be able to try to do that even better. So one of the things that Jim talked about so well is that it's not just the blood culture itself. There's a whole lot of other things that need to happen in order for paediatric blood culture to be taken well. And that involves both knowing what actual practice is, but also having education and other tools in order to address it so that we have that feedback loop. And that's what I'm going to be covering a little bit quite quickly today. So there are, we know, a lot of auditable factors that impact blood culture efficacy. So there's the pre-analytical, the analytical, and the post-analytical. So traditionally, we've all been very focused on the analytical, because that's kind of where a lot of us sit. So we sit linked to laboratories. So we think about how the actual lab testing component works. But there are obviously these other areas, so that pre-analytical in terms of the blood culture volume, the number of bottles, the timing in relation to antibiotics, and the time it actually takes to get put onto an analyzer, that we have all just been hearing about how important they are. That's even before we get into how we actually deal with those results. So looking at that post-analytical, like how do those results inform decision making? How do those results get called out at 3 o'clock in the morning? How do we make sure that the right decisions are made in response to it? And how do we then use that to feed back into our practice? So for the purpose of the new guidance, because we feel like there's been such a focus on the analytical, but the pre-analytical has kind of been left alone, or been left as having ownership of the lab, even though most of the behaviours and the education in order for implementatable change needs to happen at the pre-analytical. The guidance is very much focused on the pre-analytical pathway. Challenges is that we have these auditable factors, but mostly they have been sitting in the analytical world. So they've been sitting with us in the lab, and I've been part of a fair number of projects where we've looked at blood culture volumes before in paediatrics, but I'm not sure that we really closed the loop in terms of getting that information back to the wards in order to make the change happen. So one of the key things in terms of the NHS England blood culture audit tool is that it is there, and it will probably be captured by the laboratory, but it will also be really important that this sits within a pathway approach. So there's a neonatal and an adult version. The neonatal doesn't have the minimum blood culture volume section to it. It focuses on time to loading, and that's because we recognize the challenges. I say we, in the wider world, this is all great NHS England work that has been done. But they recognize the challenges of blood volumes in pediatrics, and so the focus in the pediatric blood culture pathway, at least initially, will be on making sure that we're getting blood cultures loaded onto analyzers in an appropriate time frame. And so recognizing that this will have to be a cross pathway approach, because it's not only time from sample taken to arriving in the lab, it's also then time from arrival into the lab and then getting onto the analyzer. And so there will be bits that can be done in the laboratory setting, but there's a whole lot of stuff that will need to happen outside of that. And this is because when we've been doing a lot of work previously, like I've done it as part of my my trainee project and other things many moons ago, even with improvements, we tend to focus on what we can do in the lab. So we tend to look at kind of whether we can use MALDI-TOF for rapid organism detection, those kinds of things. Where we probably now need to do, now we're really trying to embed this as a pathway approach, is that you're looking at that pre-analytical phase, because that's where a lot of your change can be captured. So it's looking at the behavioural change for professionals that Jim talked about, in terms of making people recognise that, you know, depending on the age and size of your patient, you may be able to take different volumes of blood. Thinking about where you get your sample from. So are you doing a central line bleed? Are you doing a peripheral stab? Talking to patients about the fact that actually, what is the best way in order to get these samples that we need, and making people aware of the most appropriate time to take the samples. And that diagnostic stewardship piece, I think, is so key, about understanding if you only have so much blood available, helping people on the wards understand the best things to do with it, so that they don't try to split it out so everything is achieved, and therefore they don't really achieve anything. And this is taken from the strategic frequently asked questions document that's come out linked to the guidance release. And I think there are a couple of things here that are really important from at least my point of view in terms of thinking about how we use these tools moving forward. And the first is that a senior management or duty holder needs to be allocated. And so this should be someone like a chief medical officer, a chief nurse, a DIPSI. And the reason that this is so important is this board to ward approach is going to be really, really key. And especially in environments where, you know, we may have outsourced our pathology, we may have one pathology lab that's serving multiple hospitals, and recognizing that a lot of our change will be focused on that pre-analytical. We need ownership at a strategic level to be able to push this forward, especially because it will form one of the CQC key lines of inquiry. And so having that senior exec representation in order to kind of have ownership, help lead some of these responses in a similar way to the fact that we have the sepsis, and also ensuring that we really do have an MDT approach to this, so that we make sure that we're including lab staff and ward staff, that we're including practice educators and infection control, and thinking where it will sit in terms of a governance structure. So will you put it through your antimicrobial stewardship groups? Will it sit through your sepsis groups? Where is the best part for this to sit? There is a steering committee in order to make sure that we're really engaging and feeding back our learning at all points. And one of the really important things, I think, as we move to actually bringing this stuff in, is to think about how we do that implementation and education step. So what kind of things are we going to have to do in order to get people even aware that this is an issue and the impact that it might have on their clinical decision making? Because I think we have to keep bringing it back to how does it impact patient care? How does it impact clinical decision making? Because that's the reason that we're doing it. And so talking about the right time to take blood cultures, producing different bits of information that says, actually, this is the guidance that you need locally that we have put in place for our patients in order to be able to really influence the practice on the wards, and making sure that that audit data therefore goes to inform what we do in terms of the education. The frequently asked questions again talk about the fact that you're not just going to be educating phlebotomists, you're not just going to be educating nurses on the wards. If we're looking at time to laboratory, you need to be working out what your training might look like for your portering staff. You need to be able to talk about to your lab staff about how long and how you get blood bottles onto your analyzer at 2 o'clock in the morning in order to make sure that you're getting them on to the analyzer within that 4-hour from bleed period. And so we have to think about what kinds of education are needed to influence at different points. And it's not going to be a one-size-fits-all approach. We have to target it so that people feel like it's meaningful for them. And so there's a really good resource that Jim and other people have created on the BSAC Infection Learning Hub that actually has different types of training in order to support you being able to start this educational approach. Because I don't know about you, but we are all kind of really, really busy people, but this is really important. So being able to access pre-developed learning tools and have the right conversations is really key. And just one last slide for me. This is just an example of a blood culture dashboard, but it's no good getting this data of our audit and not doing anything with it. And we should also be getting data of our education. And these things need to be a loop. So we need to be collecting this data, and that's great. And that's what we need to do to achieve the KPIs in terms of some of the collection of the data. But we also need to feed back that so it actually leads to meaningful change. That's me. I'm going to stop sharing. Hopefully that was a more successful thing. Right. Q&As. Did you get to any questions, Jim? So all the Learning Hub information is going to come out to you in the email link. So if so you should get access to all the links to the audit tools, just so you can look at them. Obviously the links to the guidance and to the Learning Hub, so that you guys can have a look at it and start to think about what kind of education might be required. I'm not seeing any questions in the Q&A.
There's a few questions on the chat.
In
If we work backwards, the most recent one is, do we have access to the BSAC Learning Hub, please? How do I access it?
Yeah, so you'll get the link to that. I can possibly also just put it in the chat now if that is useful to people, because I have it up. Let me just do that. Right, so that's there for you. I'm hoping I've been having a play. I wasn't involved in designing it myself, but Jim was, and I'm finding it a really useful thing just in terms of helping prepare my thinking for this session.
And then we've got lots of questions about not being able to hear you, Elaine, but then if we go a little bit back before then, there's a question about whether the presentation will be available to view and download when finished. I think it is, isn't it?
Yeah, and you'll also get access to the recording, hopefully with my absence removed, although you may have to fast forward that. Yeah, so you should get access to everything, because this is all about us trying to work together as a community in order to get the best possible outcome.
Right, and then there's a couple of questions about the BioFire BCID2 panel, and whether any of us have got experience of using that.
I've only used the BioFire for respiratory. I haven't used it for, I haven't used that particular panel for blood culture detection. I think I have used various blood culture panels previously for rapid detection linked to sepsis. In general, there are a couple of issues that I have had when doing so. One is the blood volume that you can put in. So we've just focused so much on the fact that you need to maximize your blood volume. The same can be true if you're doing any form of PCR. So if you're only doing a 200 microliter input, then actually your chance, if you've got low level bacteremia, stochastically missing that when you're taking your 200 microliters out can be quite challenging. The other thing is that you may not get enough carrier DNA in order to do a really decent extraction, depending on what kind of extraction tool you're used to. And so especially if you're doing a column-based extraction, you can lose too much of your DNA because you haven't got enough in there on your column, and therefore that can impact your sensitivity. And so and then there's all of those things about, you know, what kind of, can you do your true panel in terms of your phenotypic resistance testing growing up and typing your bugs for your AMS and your IPC secondaries. So there are definite advantages, and then there are some disadvantages that you need to just think about in terms of whether it gives you different information to a blood culture. And so obviously both things can be valuable, but you need to know what questions you're asking.
Thanks. Yeah, because I'm not sure. I think the BioFire ID, you only do that when the blood culture has signaled positive. Yeah.
Oh, okay. Yeah. So I haven't used it. I mean, we use the Sepsityper, which is the rapid moldy ID. So we get up to about 90% ID from the blood culture bottles within 2 hours. So that's my only experience, because we tend to do the phenotypic versus the PCR. I don't know, but we can find out. I mean, that's if we can find any papers or anything on it, or if anyone does have experience, let us know. I'm sure that as a community of practice, we can share and kind of work out where the best place for these things to happen is going to be, because I think that's going to be the next piece of work that happens once we are doing the pre-analytical. I know the NHS England group are already looking at some of the rapid identification techniques and looking at where the best places to put them, and starting to pull together some form of resource on that. So hopefully if you watch this space, something will come out.
Yeah, I mean, I certainly know of one centre that did evaluate the biofire in paediatrics, and I think it worked okay. But I think their sense was that it didn't really add anything to what you could do with the rapid MALDI
Yeah.
ID, and it's kind of quite an expensive technique to use, and yeah, I think it might have a place, particularly in a lab that perhaps can't turn around MALDI IDs throughout the working hours of the laboratory, and it might be that somebody who's less skilled could put something up on a biofire overnight. And I guess if you think back to my slide where we're seeing quite a lot of enterobacteriales that are actually resistant to first-line antibiotics now, but not to the point where we would be wanting to sort of give everybody meropenem. Um, eh, I could see that it could potentially have a value, but I think we've talked a lot about sort of linking with clinicians, and I think it also has to be linked with what clinicians will be prepared to do, because um, when I worked on a nice guideline development group that had nothing to do with what we're talking about today, we got a very clear steer from the clinicians that you can provide me with results at 10 o'clock at night, but it's very unlikely that we are going to change somebody's antibiotics at 10 o'clock at night, but because we don't have the infrastructure at the moment to do that. So again, I think if somebody's going to invest in technology like biofire to assist with antibiotic stewardship or making sure the patients get the right antibiotics, I think it has to be done with consideration as to whether it's going to make a clinical impact.
Yeah, completely. I think it's all about what's the best way to inform our clinical decision making. So Peter's asked, and I don't know if you got to this while I was offline, Jim, about if you take 10 mils of blood, is it prudent to use a single aerobic bottle or multiple pediatric bottles? I think most of the data out there says that a single aerobic is probably the way forward, unless you are thinking about fastidious or gut related infections. But I don't know, Jim, whether you've already covered that.
No, I haven't covered that. I mean, I think I would tend to agree nowadays, but because I think probably in the days before meningococcal immunization, when meningococci were probably in our top 5 blood culture isolates, and they're almost non-existent now. I think there was possibly an advantage to the pediatric bottles, because I think they were better formulated for supporting the growth in nice areas. But I think now it's if you have an adult blood culture bottle to hand, it probably makes more sense to use that.
Lovely. Someone's very helpfully put in some of the panel stuff linked to the biofire in the chat, if that's useful. Jim, there's one about heel pricks and biochemistry. Do you guys use heel pricks routinely in your biochem for anything other than CRP?
Yeah. I think we can do a sort of full biochemical profile on a heel prick if we get enough blood. But again, I think that's one of the privileges of working in the Children's Hospital with its own laboratories, because our laboratories have always procured analytical equipment that will take small volumes and wouldn't accept anything else, and that might not be the case for a lot of hospitals that are sort of mixed pediatric and adult.
Yeah, we're the same. So because we're pediatric, we're validated on small volumes. I don't know how widely in a mixed world people have gone ahead and done that. But I think, again, it's one of those things that it's getting us to ask the question of our colleagues and saying, this is coming in, we need to be thinking about it. And as part of that pathway approach, reaching out and saying, actually, you may not be currently validated. Can we look at doing something like this in order to kind of tie up with that pre-analytical change on the wards and getting them involved in the conversation? Because I also think that it's too easy for this just to sit with micro and infection specialists, and actually there's a much wider conversation in terms of that diagnostic stewardship that would be beneficial to have point of care testing colleagues, but also wider biochem involved with. Are there any other questions that people want to quickly put into the chat that they've been thinking about whilst we talked? If not, I'll ask Jim quickly. Is there anything else that you have thought of that would be useful to share before we wrap up?
Not really, but I found it really very interesting and thought-provoking. Just listening to what we've been talking about for the last few minutes, and particularly what the thing that I hadn't really thought of before, because I'm very much into, and it came out of my presentation, the sort of liaison with clinicians, but I'm beginning to think actually the range of stakeholders is even wider than that. And certainly involves our other laboratory colleagues, and might even involve sort of parents and nurses as well, just to try to sort of make everybody understand that central to the investigation of infection is getting the right sample, but we have to do that in the context of all the other things that we've heard about this lunchtime.
Yeah, I think when you sit down and talk about all of these things, suddenly your appreciation of who your key stakeholders are does change as you start to actually work through the question. And I think even just writing the talk, it made me realize quite how broad you need to go to be able to really address some of the outcomes that we've been asked to achieve. I just got asked in terms of the MALDI-TOF about whether it was via the extraction workflow or the direct transfer and extended. So we do a combination. So we do, we found that a lot of our gram negs are absolutely fine in terms of doing the straightforward extraction. For some of our gram pos, what we've ended up doing is doing a plate inoculation, a 2-hour growth, and then just doing a scrape. Even if you can't really visualize it, and that's usually enough to get an ID. And so that's how we got ourselves up to kind of 90% plus fairly throughout. And Emma pointed out that actually some of the stuff linked to COVID, it's a really good time for us to think about, because we had to do a lot of rapid diagnostic work linked to COVID. I don't think we're probably in quite as difficult a situation as we were when this guidance was originally being drafted pre the pandemic, because I think people are so much more used to needing to really closely link in with their labs for rapid turnaround time. And so hopefully that has put us in good stead. And I think that's what Emma's point is. Okay. Yes. I mean, all of this, now that all of our guidance testing is, and I suppose it's, we won't necessarily be able to maintain it in the same way because of the fact that COVID testing is changing. But I think it's working out which bits are key and having those conversations with stakeholders about pathways still being maintained, and can we flex them to enable us to fulfill a different purpose. And so having those conversations early is really important. And one last thing from Richard, because we're close on time. Any consideration on having analyzers outside of the laboratory, Jim? Any thoughts?
Yeah, I mean, I think this is one of the kind of things where COVID has gotten in the way a bit, because certainly there are blood culture analyzers now that can run with satellite units that will speak to the central unit in the lab, and we were very much going down that line. And then COVID came along, and like Emma, we've got a 24-hour COVID testing team, and we're using those to load blood cultures in the lab at the moment. But certainly, I mean, I think if we want 24-hour loading of blood cultures, there seem to be three options. You either have a microbiology lab that's staffed 24 hours a day, or you speak to your colleagues in blood sciences and see whether they can look after blood culture loading out of hours, or you place some satellite units in higher use areas of the hospital, or you come up with some combination of two or more of those.
Yeah, I think we currently run 24 hours, but I suspect that we will move to having our biochem colleagues loading our analyzers overnight. So we are at time. I'm very sorry that I have disappeared partway through, and I hope that it didn't disrupt things too much for you. So just to reiterate, you should get recordings of this session. You should also get some of the useful links that we've talked about, and I hope that this is the start of a conversation, and that we as a community can continue to chat and learn from each other, and feel free to share the learning that we have. So thank you so much for spending your lunch hour with us. I know how busy everyone is. Goodbye.
Thanks very much, Elaine. Bye, everybody.
Sorry, I should have
Thank
thanked Jim.
you. Thank you both, and thank you everyone for joining.
Thank you so much for that, Jim. You were a rock star. And sorry for abandoning you partway through. Or you on mute.
Right. Okay. I actually found that really thought-provoking. That was really useful.
Yeah, I think it's as useful for us as it was for them, I hope. I just think it causes you to think about stuff in a completely different way.
Yeah, because I think somebody made a comment. They'd trained porters to load blood culture.
Yeah,
gosh, we don't have any porters.
Yeah, I mean, if I tried to get our porters to do that, I think there'd be a riot.
Yeah.
How do you deal with like the analytical follow-up then on your satellite blood culture machines? Do you just have someone that goes and collects them periodically when they flag?
Oh, we've never actually done it because, as I said, we had everything organized, and the plan was that yes, we'd go around and collect them, and I think it's the thing that every hospital is so different, because we have we don't get any specimen deliveries from the main hospital portering service, but we have our own laboratory porter, but only one.
Oh my gosh.
Who sort of starts work at about 7:30 in the morning. And the plan would have been that he would have gone around and sort of gathered all the blood cultures and taken them back to base. But we've never actually done it because we kind of have a 24-hour COVID testing team that of people we've recruited, you know, who are either still at university or have just finished university and are waiting to go to a job, and they're amazing people. They're actually, as a group, I think they're much more switched on than half of biomedical scientists. But they've been sort of gradually doing more and more work, because there's been less and less COVID testing to do.
Yeah. And I suppose it's how we use that resource, isn't it, in a bit of a new and interesting way, in order for us to kind of make those improvements elsewhere.